Good morning, everyone, and welcome to this morning's session of Tyro Multidisciplinary Seminars. I'm Mark Erkin from here in New York, and we have a great opportunity this morning to learn from one of my colleagues at NYU, Dr. Kepal Patel, who is the Vice Chair of the Department of Surgery at NYU Langone. Dr. Patel is also Chief of the Division of Endocrine Surgery and Director of the Thyroid Cancer Interdisciplinary Program. He is widely published and very active at both national and international level. He is a founding member and treasurer of the North American Society of Interventional Thyroidology. Dr. Patel was invited, which is a significant honor, to give the annual lecture of the Year in Thyroidology Surgical Science at the most recent 2022 ATA National Meeting. And it is that lecture which forms the backbone of this morning's talk on that same topic. So I would like to welcome Dr. Patel and thank him in advance of his lecture. As always, I encourage everyone to send in your questions. I will do my best to get to those questions before the end of the hour. So Dr. Patel, thank you very much for joining us this morning.
Well, thank you. Thank you very much for inviting me. It's truly an honor to be here this morning. And I look forward to sharing my talk and discussing any questions. So let me share my screen. Excellent. All right. Thank you very much once again for inviting me. It's a true honor to be here. So I will be discussing the year in surgical thyroidology, and this is, as Dr. Erkin mentioned, based off the talk that I gave at the annual ATA meeting this past October. I've updated a couple of slides and added a little bit more information, but the gist of it remains the same. And the goal of this was really to summarize what's happened in the world of thyroid surgery in the past year or two. What new advances have occurred? Where are we going? And so kind of keep everybody up to date on this field from a surgical perspective. So I have no disclosures at all, except for the fact that this was a very difficult task when I was first asked to do it. Combing through hundreds and hundreds of papers, trying to pick out the ones that I felt were the most relevant and the most interesting was not an easy task. I take full responsibility. If there's any paper that I left out, if somebody feels that, oh, why wasn't my paper quoted or cited, that's on me, and I apologize up front. But this was, like I said, an extremely difficult task, and had to kind of really figure out which papers we were going to present in a limited amount of time. And the views and opinions are strictly mine, so anything I say is not a guideline statement. It's not a society-based statement. It's clearly my opinions and my views, and you are absolutely entitled to completely disagree with me if you want, and I appreciate that. So what was the criteria? So really, I said we focused on papers that were presented over the past year within the field of surgical thyroidology. I tried to give priority to original research studies which were potentially practice changing. And I really tried to exclude reviews, consensus statements, and guidelines. But you'll see I have included one or two of those just because some of those statements and guidelines had a lot of important information that I thought was necessary to share with the audience. So what are our learning objectives? Well, first I want to talk a little bit about what's new. And so we're going to focus on parathyroid detection. I talk a little bit about thermal ablation, really kind of what's up and coming, what are the future applications for thermal ablation. And then I'm going to focus on what's new again. And these are the age-old questions that we hear about over and over again for the last couple of decades now. Lobectomy versus total thyroidectomy. What's the role for prophylactic central neck dissection? And a little bit more data and information on laryngeal nerve monitoring. And the reason why we keep talking about these topics is because there are some really good data that have come out over the last year or two, kind of enhancing our understanding of these fields. And I think it's important to understand and to appreciate some of that data. So let's start off with what's new. So parathyroid detection. So I think, in the world of surgery, many of us are somewhat familiar with this new technology. This is what we refer to as near infrared autofluorescence. The parathyroid glands themselves do emit autofluorescence. So if you have the appropriate camera and light source to detect this, you can actually see these parathyroid glands light up in the OR. And this is an example of what that looks like. So if you look at image A, you see the parathyroid glands with the arrows are pointed to the glands. And then when you actually flash the camera, you'll see these glands can actually light up. And so, this technology can be used in the operating room to help identify parathyroid glands. And why is that important? Well, as we all know, injury to the parathyroid glands during thyroid surgery is really a devastating complication, and proper identification of the parathyroid glands is critical. And this is really where this technology can potentially be useful. But the question obviously is, does it really make a difference? And if so, in what context? So this is a little bit of an older study, but I wanted to present it because I think this was the original study that really kind of laid the foundation and the stage for looking at autofluorescence-based detection of parathyroid glands. And this was actually a multi-center randomized clinical trial run out of France, looking at the association of autofluorescence with postoperative hypocalcemia risks in patients who are undergoing total thyroidectomy. And they basically randomized patients from 2016 to 2018 with a 6-month follow-up at 3 different referral hospitals. And they had 123 patients that were randomized into the near-infrared autofluorescence arm, and 122 patients who were randomized into the standard surgical arm. And they were able to analyze 121 patients on one side and 120 patients on the other side. So it's a pretty nice randomization. And they used the endpoint of hypocalcemia detected up to 1 week postoperatively, and their definition of hypocalcemia was a calcium level less than 8. And so basically, they looked at 241 adults, and what they found was that the use of near-infrared autofluorescence during total thyroidectomy helped lower the temporary postoperative hypocalcemia rate from 22% to 9%, and it lowered the parathyroid autotransplantation rate and the inadvertent resection of parathyroid glands from 16% to 4% and 14% to 3% respectively. So they were able to show that using this technology, that the rate of temporary postoperative hypocalcemia did decrease. They were able to identify the glands and prevent parathyroid autotransplantation as often as they were doing when they weren't using the technology, and decrease the inadvertent resection rate of parathyroid glands. But did it make any difference in the long run? And the answer was no. 6 months, there was absolutely no significant difference whether or not you use this technology. So, moving ahead, looking at not just patients who had total thyroidectomy, looking in the context of total thyroidectomy and central neck dissection. So those are the patients we worry a little bit more about when we talk about parathyroid injury, because when you do a central neck dissection, even though you potentially save the parathyroid glands, there's a possibility that you may have devascularized them, that they may not be as healthy as they would have been if you did not do a central neck dissection. So these were patients who had total thyroidectomy and central neck dissection, and you look at the role of near autofluorescence technology in that context. And what they saw in that situation, it was a retrospective analysis looking at 542 patients, and there were 2 groups, the group with near-infrared and a group without near-infrared technology. And once again, when they used near-infrared autofluorescence, they decreased the temporary hypoparathyroidism rate from 46% down to 33%, but there was no difference in the permanent hypoparathyroidism rate at 6 months after surgery. There was, once again, a difference in the inadvertently resected parathyroid glands, which was lower in the group that used the autofluorescence technology. So long run, this did not look like it actually added much benefit, but in the short term, it did decrease the risk of temporary hypoparathyroidism. So, I mean, I think the question really is, are we looking at this in the context of just saving the glands, or are these glands actually perfused? And that's an important concept, because the autofluorescence does not give you information about the actual viability of the gland. It just tells you this is where the gland is. But is that gland actually being perfused? Is that gland actually viable? And so the thought process behind this paper was to combine autofluorescence with indocyanine green fluorescence in the identification and evaluation of parathyroid glands during total thyroidectomy, to see if not just identifying the glands, but actually identifying them and showing that they're being perfused, if that made a difference. And this was a randomized controlled trial. So it was a combination now of autofluorescence and indocyanine green fluorescence to look at the perfusion. And this is kind of what it looks like. So if you see over here, this is just standard white light on the first diagram A. If you look at that standard white light, you see kind of what the parathyroid glands would look like. And then when you use autofluorescence imaging, you see the parathyroid gland in B and E, you see lighting up as a white gland. But then when you use the indocyanine green, you actually see the gland lighting up as green, telling you that this gland is actually being perfused. So they randomized 180 patients. The control group, the parathyroid glands were identified and evaluated by the naked eye. In the group that had the near autofluorescence with the ICG, the NRAF, the NIRAF was used to identify the parathyroid glands, and the ICG was then applied to assess the blood perfusion of the parathyroid glands in situ. The combined use of near-infrared autofluorescence and ICG during total thyroidectomy once again reduced the risk of transient hypoparathyroidism from 43% to 27%, and enhanced the ability to identify the parathyroid glands and preserve the parathyroid glands. But there was no difference in permanent hypoparathyroidism, even with the addition of ICG. So, I think one of the things to think about when you look at these last few studies that I showed you is that these studies were all done at high volume centers with high volume surgeons. And I think most of us would argue that, high volume surgeons probably overall have a low incidence of permanent hypoparathyroidism, which is great. We want our patients to really do well. And so, is this technology really being assessed in the correct context? If you're assessing this in the context of high volume surgeons who already have a low rate of permanent hypoparathyroidism, it's going to be very hard to improve upon that with this new technology. So I thought this paper was really kind of interesting because it looked at comparing the intraoperative parathyroid identification based on surgeon experience versus near-infrared autofluorescence detection. And this was a surgeon-blinded multicentric study. So this was done at 3 different centers with the surgeons being blinded to the technology. So they actually use the technology, but the surgeons were not told what the actual colors showed and what the sounds that they heard. So they were actually blinded to the actual technology. So it had 3 junior surgeons, which were defined as less than 5 years of experience, 3 senior surgeons, which was defined as greater than 10 years of experience. The senior surgeons were able to identify parathyroid glands with higher confidence and have a lower tissue misclassification rate per specimen. The near-infrared autofluorescence had an overall 93% accuracy, which was very similar to the surgeons who were in practice longer. So the senior surgeons were able to have the same level of confidence and identification of parathyroid glands as the technology. So it kind of makes sense now that the technology doesn't really add much in the context of somebody who's been doing this operation for a long time and has that level of experience. So the conclusion of the study really was, should we be looking at these technologies in the context of maybe low volume surgeons or in the context of non-endocrine head and neck surgeons who perform neck operations, and really to evaluate the benefits of this near-infrared autofluorescence technology? It should be done with respect to the variability in surgeon volume, specialization, and technique. And as we all know, and we hear these data all the time, is 70 to 80% of most head and neck endocrine surgery in this country is done by not high volume surgeons. It's done by low volume surgeons. It's defined by less than 25, 30 cases per year. And so maybe the actual benefit of this technology would be in that context of patient care. And I think that's really where this probably should be studied, and maybe would have its best benefit. So I think that's kind of where this technology is probably going to be evolving. The other little caveat, I'm having played with this tool a couple of times now. I think the other area where it may be beneficial is in those rare situations where you have recurrent hyperparathyroidism, where there may be a parathyroid gland buried in scar tissue. It may be difficult to identify. I think in that context, this may have some benefit. But like I said, I think these technologies should probably be studied in the appropriate context. So let's move on a little bit now to thermal ablation. So what's new in the world of thermal ablation? Well, I think there's enough data now. I think all of us are pretty familiar with the utility and the effectiveness of using thermal ablation, specifically radiofrequency ablation, in the context of symptomatic benign nodules. And I think that data is out there. And I think most of us agree that it is a good option for patients with symptomatic benign nodules, and once again in the right situation. But my feeling is that this technology is just now starting to take off, and really one of the areas where this technology is going to be most useful is in the context of thyroid microcarcinomas. And so this was a great paper looking at ultrasound guided radiofrequency ablation versus thyroid lobectomy for low-risk papillary thyroid microcarcinomas. And it was a propensity matched cohort study looking at 884 patients. So why this patient population? Well, I think we all know that with this patient population, active surveillance is wonderful, works beautifully in the right patient. But there's a subset of patients who hear the word cancer, don't necessarily feel comfortable with the concept of active surveillance, however, don't really want to have quote unquote, surgery, what they would think as being aggressive in the sense of having half their thyroid removed or their entire thyroid removed, potential need for thyroid medication, et cetera. So in that context, I think we have a good subset of patients who want something done, don't want to go all the way to the end of surgery, but don't necessarily feel comfortable with active surveillance. And I think this technology will fit into that picture perfectly. So what is propensity, real briefly, what is propensity score matching? Because I'll talk about it later in one of the other studies as well. Propensity score matching is a statistical matching technique that attempts to estimate the effect of a treatment, accounting for all the covariates that predict receiving that treatment. And so the major advantage for this is really comparing oncologic outcomes from non-equivalent groups by reducing its bias. So it basically takes the effect of a treatment and tries to account for it, predicting whether or not somebody's actually going to receive that treatment. So it's a nice little statistical tool. So this paper looked at 2,000 patients who had unifocal low-risk papillary thyroid microcarcinoma, and they had around 1,800 patients who chose surgery and 500, close to 600 patients who chose radiofrequency ablation. They had several exclusion criteria, such as total thyroidectomy, central neck dissection, not enough follow-up. So ultimately, they ended up with 460 patients who had on the surgery arm, and then 424 patients in the RFA arm. And then after the propensity score matching, they ended up with 332 patients in each arm. So 332 patients who had a lobectomy for papillary microcarcinoma, and 332 patients who had radiofrequency ablation for papillary thyroid microcarcinoma. And what did they find? Well, not necessarily surprising. Even up to 72 months, there was no difference in the recurrence-free survival, whether you had a thyroid lobectomy or radiofrequency ablation. So once again, that's not necessarily surprising. These patients are low-risk patients. As we know, active surveillance also works beautifully in these patients. So not surprising that these patients had no recurrence-free survival, but this at least shows that radiofrequency ablation is a potential option. And so they said radiofrequency ablation was comparable to thyroid lobectomy as far as recurrence-free survival was concerned. Radiofrequency ablation was associated with a shorter procedure time, lower cost, lower estimated blood loss, shorter hospitalization, and lower complication rates. This was the largest study to compare the clinical outcomes of these two options for low-risk papillary carcinomas. And in the absence of prospective or randomized clinical trials, which I'm sure we probably will not be able to do, this particular statistical analysis shows comparable outcomes between radiofrequency ablation and thyroid lobectomy. And the other thing that was also mentioned but was not really discussed in detail was the use of postoperative thyroxine or thyroid hormone. With radiofrequency ablation, none of the patients needed thyroid hormone replacement. And unfortunately, but obviously with surgery, there was a significant number of patients who ended up on thyroid hormone supplementation. So that's another important factor to consider. So what are some of the limitations? Well, this was a retrospective study. The follow-up duration was relatively short for thyroid cancer. And the cost utility analysis is going to be very important when we start thinking about these procedures. And that's going to really depend on the varying practices in different countries. So is radiofrequency ablation cheaper versus or more cost effective? Let me say that, more cost effective than thyroid lobectomy. Once again, that'll depend. In this country at this point, there is not a CPT code for radiofrequency ablation, so we can talk about that later if anybody has questions. But that may be not that far away from happening, so that may change the cost effectiveness of that procedure. This study only compared 2 arms, but I think ideally, like I mentioned before, there should be a 3rd arm looking at active surveillance as well as we move forward. So let's go to total thyroidectomy versus thyroid lobectomy. So for me, this is the age-old question, right? And it's almost as similar as for anybody who's a basketball fan out there. The argument of who's better, LeBron James or Michael Jordan. I don't think that question will ever really be solved. I think people will have their favorites, and old timers like me will always say Michael Jordan. But I'm sure, like my son looks at the argument, he says there's no discussion. It's LeBron James, and so we'll see how this all pans out. But I think for us, as far as thyroid lobectomy, total thyroidectomy, why do we keep talking about this? Because there are new data that have come out, and we'll talk a little bit about some of the quality of life data that have come out as well. So this was a really a nice paper that came out of our colleagues at Sloan Kettering. Senior author was Dr. Ganley, a good friend and colleague, looking at surgical management of low and intermediate risk node negative thyroid cancer. And this was a single institution, once again, using this propensity matching analysis to compare thyroid lobectomy and total thyroidectomy. And over here, basically, you see they had over 6,000 patients who had well-differentiated thyroid cancer. After they went through their exclusion criteria, they basically ended up close to 1,918 patients each arm. So it was 918 patients matched who had lobectomy, matched to another 918 patients who had total thyroidectomy. And these were all low to intermediate risk patients who were node negative, which is important to remember. And once again, not surprising, even going out to up to 120 months, there was no difference in the overall survival, which we've already kind of known for a while, that these patients really do well, whether you do total thyroidectomy or thyroid lobectomy. There was absolutely no difference in disease-specific survival between these two groups, once again, out to 120 months. There was no difference in the recurrence-free survival between these two groups. And so basically their findings is that thyroid lobectomy has an outcome which is equivalent to that for total thyroidectomy in selected patients with ATA low and intermediate risk of recurrence. So why was this paper really, and this paper, obviously, we were familiar with this data. It was a very well-written paper. It uses this new statistical analysis, which I thought was kind of neat. But the other aspect of this paper that I thought was really interesting was 402 patients were actually ATA intermediate risk, not even low risk. We're talking about intermediate risk of recurrence, of which 212 of those patients had a total thyroidectomy, and 190 of those patients had thyroid lobectomy. Even in that subset, there was no difference between recurrence-free survival, overall survival, disease-specific survival. So I know we've always focused for the longest time on low-risk patients, but even for intermediate risk patients, we know that thyroid lobectomy is a good an efficient operation for this subset of patients. There were no statistical differences noted between the two groups when we looked at all the different survival curves. So I think this once again, shows us that a thyroid lobectomy is a good operation for these low to intermediate risk patients. So it adds more data to what we already know. What are some of the limitations? Well, this is a tertiary care center with experienced sonographers and experienced thyroid surgeons. So this recommendation may not necessarily translate to institutions where there's a lower surgical volume and where the radiologists may have less experience in identifying suspicious findings related to thyroid cancer. Obviously, patients' preferences, financial status, and ability to attend follow-up visits are essential factors to consider. So, when we're doing, procedures, whether it's radiofrequency ablation, whether it's thyroid lobectomy, a lot of these procedures, we're really dependent on our colleagues in radiology, in pathology, to kind of guide us and make sure that we're doing the right procedures, right? If you have radiologists that are really good at looking at lymph nodes, really good at identifying extrathyroidal extension, looking at the features of the tumor itself, it may help you decide whether a lobectomy is the right operation or whether that patient should be having an upfront total thyroidectomy. And I think these are factors to consider. If you're working in an area where the patients may not be able to attend follow-up visits, where patients may get lost to follow-up very easily, in those situations, maybe a total thyroidectomy is the appropriate answer. So I think you have to take all of these studies in the context of the practice that you're in. So let's talk a little bit about quality of life, because I think, I get this question very frequently from a lot of my patients, as I'm sure most of you do, is, how am I going to feel after thyroid surgery? And if I had a thyroid lobectomy, and I'm saving half my thyroid, am I going to feel better than if I took out my entire thyroid and I'm completely dependent on thyroid medication? And so I think this is really where, a lot of our work should be focused on, and we should be including quality of life in almost every study that we do when it comes to managing patients with thyroid cancers, because this is really kind of the long-term effects of what we do is going to be really important. So this paper looked at total thyroidectomy versus thyroid lobectomy with the quality of life of patients in low to intermediate risk of recurrence, well-differentiated thyroid cancers. And so this was a prospective observational longitudinal cohort study looking at low to intermediate risk DTC from 2018 to 2019. They had patients who had thyroid lobectomy and total thyroidectomy, and they were evaluated preoperatively and postoperatively at 1, 3, 6, and 12 months using 3 HR quality of life related questionnaires, looking at complications and looking at their serum thyrotropin levels. They had a total of close to 1,000 eligible patients, of which 563 had lobectomy and close to 500 had a total thyroidectomy. And what did they find? Well, these are some of the symptoms that they looked at: neuromuscular symptoms, voice changes, sympathetic symptoms, and tingling. And what you see here is initially, if you look at the first up to 1 to 3 months, patients who had lobectomy tended to do better across the board in most of these symptoms. But if you go out to 6 to 12 months, it all kind of equalized. So as you went out, it didn't really matter whether they had a lobectomy or total thyroidectomy. But initially, that first 1 to 3 months, patients did feel better when they had a thyroid lobectomy as opposed to a total thyroidectomy. So compared with the thyroid lobectomy group, including the 1 to 4 centimeter subgroup, the total thyroidectomy group experienced more postoperative problems at 1 and 3 months. And that included more anxiety, more depression, more fatigue, pain, voice changes, appetite loss, financial difficulties, which is really important in the world of thyroid medicine, thyroid care, chills, tingling, you name it, sexual symptoms, decreased physical and emotional and social function. But the key here was none of these differences were statistically significant at 6 months postoperative. They almost all disappeared by 12 months. So even though initially it looks like thyroid lobectomy may be beneficial for the first couple of months, in the long run, it probably doesn't make much of a difference based on this one study. It is a single center study. Many patients did not respond to the questionnaires, could be attrition bias. The follow-up duration was relatively short. And there are some other studies to suggest that the need for thyroid medication may contribute to the overall quality of life. So that's another area which, in the interest of time, I won't be able to get into, but I think that's another area that we need to focus on. So moving ahead, looking at prophylactic central compartment neck dissection. Once again, why are we still talking about this? Because at this point, most of us do not perform prophylactic central neck dissection, except for select situations, but some still do, and there's no, once again, there's no necessarily right or wrong answer. But there are very few randomized trials looking at this, and this was a prospective randomized trial, so I thought it was important to kind of mention it and discuss it a little bit. So I thought this was pretty interesting. So this is a busy table, but I think the one thing to take away from this table is that if you look at the group that had a total thyroidectomy, and then you compare it to the group that had a total thyroidectomy and the central neck dissection, the overall size of the dominant nodule was pretty small. These are not big tumors. These are overall pretty comparable groups for the most part, which I like, whether it was the BMI, whether it's the distribution of patients, the age of the patients, everything was pretty well matched between the two groups that had, whether you had a total thyroidectomy or a total thyroidectomy with a prophylactic central neck dissection. And there were 50 patients in each group. And so once again, this was their cohort here. Their exclusion criteria included intraoperative node enlargement, so that would not be prophylactic at that point. That would be a therapeutic neck dissection. Anybody who had robotic surgery or had benign pathology were excluded. And so basically we ended with close to 50 patients in each group. And this, once again, very busy slide, but what I want to focus on this slide is this data right here, looking at the number of lymph nodes retrieved. So even in the group that had just a total thyroidectomy, there was still about 2 lymph nodes, plus or minus 2 lymph nodes that were retrieved. And this happens all the time. Even in patients who do total thyroidectomy, we'll often see small lymph nodes that are removed with the thyroid gland itself. Obviously, there were more nodes removed in the group that had a prophylactic central neck dissection. The group that had a prophylactic central neck dissection also had more number of metastatic nodes. Once again, not a surprise. You did a neck dissection, you're probably going to find, indolent and hidden metastatic lymph nodes that otherwise you wouldn't necessarily see. But most of these were still micrometastases. There were some that did have extra nodal extension in the prophylactic group. But the key here is that no patient showed structural recurrence up to close to 50 months post-op. Both groups had similar rates of surgical completeness and success of ablation. There was no difference in incidence of complications. More patients were upstaged, no surprise there, if you did a prophylactic central neck dissection. Radioiodine ablation treatments and a total dose of radioactive iodine did not differ between the two groups, and there was no difference in the number of patients who had a post-treatment thyroglobulin less than 1. So in general, they concluded that the role for prophylactic central neck dissection in improving overall prognosis was limited, and they did not recommend to do that, except, like I said, in certain select situations. Once again, this is a short follow-up. A small number of patients were enrolled, and the key here, once again, is every surgeon that was involved in the study had greater than 10 years of experience in a large volume center. And why is that important? Because often we talk about risks of complications associated with prophylactic central neck dissections, and once again, in experienced hands, these are safe operations with low risk, comparable risk to just doing a total thyroidectomy. But as I mentioned before, majority of thyroid surgery in this country is not done by high volume surgeons, and so it's critical to remember that if you're doing a prophylactic central neck dissection, you don't do these operations that often, you probably will have a higher risk of potential postoperative hypoparathyroidism or even a potential recurrent laryngeal nerve injury. So it's important to remember that. So talking about recurrent laryngeal nerve, so once again, this is an area that that has been exhausted. People have talked about this for over 20 years now. The role of nerve monitoring, does it really improve, or prevent injury to the recurrent laryngeal nerve? And we'll talk about a paper in a couple of minutes that addresses that. But the reason I wanted to present this paper was really because the one thing that this paper did really well was talk about the anatomy of the recurrent laryngeal nerve. And so this was a result of looking at over 1,000 monitored nerves from the International Neural Monitoring Study Group. It was an international study to help understand the surgical anatomy, the variability of the recurrent laryngeal nerve from a worldwide perspective, establish potential correlates between nerve injury and the electrophysiological response. They looked at over 1,000 nerves at risk, looking at 17 centers from 12 countries and 5 continents. So this is really a large study, one of the largest studies looking at recurrent laryngeal nerve anatomy. And this is a really nice depiction. And the reason I put this up, most of the surgeons in the group are very familiar with this anatomy. This is what we do day in and day out. We look for the nerve, we make sure we stay away from the nerve and not injure it. But as we start doing more and more of these interventional procedures, whether it's radiofrequency ablation, whether it'll be microwave ablation, laser ablation, high frequency ultrasound, whatever else is coming down the pipeline in the world of technology. And there's a lot, by the way, coming out, especially looking at doing interventional procedures with combined robotics and combined AI. I mean, it's all happening. And it's not necessarily even going to be driven by us. It'll be patient driven, interventional, radiology driven, et cetera. But you need to understand the anatomy of what you're treating. And if, for example, if you look at the two Bs here, the left and right, these nerves have ventral displacement. They're actually running right along the upper pole of the thyroid gland. This is not the standard anatomy, but this does happen in a small subset of patients. Also understanding the situation where you have a non-recurrent laryngeal nerve, especially on the right side, which may be coming directly into the larynx, right along that upper pole area, coming right off the vagus nerve. And why is that important? Well, if you're ablating a 1.5 or 2 centimeter nodule in the right upper pole, and all of a sudden now you have a patient who has nerve injury, well, you need to understand that, that anatomy of that nerve may be such that that nerve was running right along the capsule of the gland, right where you were administering the thermal ablation, causing damage to that recurrent nerve. So I think as we do more and more non-invasive interventional procedures, especially for some of our non-surgical colleagues, I think it's going to be really important to understand the anatomy of what we're treating to potentially avoid injury. And that's why I thought this paper was really good to kind of show some of those anatomic variations. What was interesting was they saw that 23% of nerves traveled what they referred to as an abnormal intraoperative trajectory. They lost the signal in about 3.5% of the nerves. Most of the nerves that they lost signal had an abnormal trajectory. What was really interesting was that traction injury was the most common form of injury to the nerve, but was found to be less recoverable than previous reports. And so previous reports have always stated that within 6 months, most recurrent laryngeal nerves that have had traction injury would recover. However, this showed that it was only about a 62% recovery when you had a traction injury. So that's actually much lower than what has been previously reported. Once again, intrinsic limitations to this study. It's a large database study. It's going to really depend on how the data was entered. So, there's always going to be limitations when you do large database type of studies. But I thought it was interesting to kind of mention, at least from the anatomic perspective. But this study I wanted to end on really was one of the few studies that actually shows that using intraoperative nerve monitoring may actually reduce the risk of recurrent laryngeal nerve injury. And this was a doubly robust approach, which we'll talk about, published in the Annals of Surgery in October of 2022. And this was the largest study to use a national surgical outcomes registry, and the first study to use this doubly robust approach to look at the effect of nerve monitoring on recurrent laryngeal nerve injury. And so what is a doubly robust approach? Well, it really fits two models into one. You create a treatment model that estimates the probability of receiving that treatment. So in this case, it would be what's the probability that you're going to receive intraoperative nerve monitoring. And then it creates weights based on the inverse probability of that treatment. And then it uses an outcome model using those coefficients from the treatment model to predict outcomes of interest. And in this case, the outcome of interest would be recurrent laryngeal nerve injury. So what's the likelihood that you're going to receive nerve monitoring? And then you compare that to what's the likelihood that you're going to have recurrent laryngeal nerve injury. And so they looked at over close to 24,000 patients, of which around 16,000 had intraoperative nerve monitoring. And they found that nerve injury occurred in approximately 6.2% of the cases. So it's a little bit higher than what's quoted in the literature. Rates of recurrent laryngeal nerve injury increased with increasing age, BMI, with a cancer diagnosis, with previous neck operations, higher in patients who had total thyroidectomy versus lobectomies, and higher in patients who had a node dissection. The doubly robust model suggested that the use of intraoperative nerve monitoring was associated with significant reduction in overall nerve injury. And you can see over here the risk difference fell from approximately 2.6% down to 0.88%. And so that's really kind of what they showed using this model, this statistical model, and looking at the use of nerve monitoring. And I brought this paper to attention basically because it's one of those few papers that actually have shown statistical difference in actual nerve injury occurrence. So what are the limitations? Once again, this is a data set study. It's limited by its retrospective nature and its 30-day time horizon. And once again, these data is only as good as the people that put them in. And so you always have to keep that in mind. Some of the patients who reported hoarseness may actually be from other causes. So when they talked about 6.2% nerve injury, not all these patients had a formal laryngoscopy postoperatively to really show the gold standard to show that they actually did have a nerve injury. So a lot of this was reported as nerve injury, but was it really nerve injury or not? Hard to tell. That's a big limitation of this study. It may not actually be a recurrent laryngeal nerve injury, and it could just be from direct vocal cord trauma or endotracheal intubation. And it could not account for surgeon volume relationship. So although the study does have some benefits, it also had some significant limitations. So on that note, I'm going to kind of end, give people time to ask questions. So in summary, what did we learn over this past year from a surgical perspective? So we learned that radiofrequency ablation is a potential treatment option for low-risk papillary microcarcinomas. We learned that thyroid lobectomy is reasonable for low-risk and intermediate-risk papillary thyroid cancers. We saw that quality of life is perhaps initially better with thyroid lobectomy, but over time, it equalizes out whether you have lobectomy or total thyroidectomy. And some of that may have to do with the need for thyroid hormone supplementation. We show that prophylactic central neck dissection does not really improve recurrence-free survival. We kind of learned that intraoperative nerve monitoring does seem to increase the incidence of laryngeal nerve injury, and understanding the anatomy of the recurrent laryngeal nerve is going to be critical, especially as we move forward doing more interventional-based procedures. And finally, surgeons love toys. We love playing with things. We love fluorescent colors, which may help reduce injury to the parathyroid glands. So on that note, I want to say, once again, I have no disclosures. Thank you very much for inviting me to speak, and I'm happy to answer any questions or talk about whatever anybody wants to talk about. Thank you.
Terrific. Kepal, thank you very much. That was really an outstanding presentation, one that I know a lot of people will have tremendous interest as they review this. I just want to see, I believe we've got some questions. One is from one of your colleagues at NYU. Dr. Persky is asking whether or not there is a difference in, I assume, outcomes between RFA performed by surgeons versus endocrinologists. Do you have any data related to that?
Yeah, so there actually are no data on that at all right now at this point. I think all the data, at least in this country, we're still accumulating. Most of the data that's available internationally is actually non-surgical. Most of the, like, for example, the largest experience out of South Korea is Dr. Baek, who's considered the godfather of radiofrequency ablation. He's an interventional radiologist. And so that's, like Steve Hodek and I both went to South Korea in 2019 to watch him operate. And he has an RFA machine going on over there. And his, incidence of injury is super low. He has great outcomes. And I think, like with anything else, it's all going to be experience. So for example, there's really good data on radiofrequency ablation, looking at your first, give or take 20 to 30 cases, and how much energy you actually deliver to the nodule. And you can calculate that, the number of joules that are actually delivered to the nodule. And it's actually pretty low if you think about it, which kind of makes sense, right? Because I can tell you, my first couple of cases, you're a little hesitant to deliver a lot of energy. You don't want to damage surrounding tissue, surrounding structures. But as you get more confident and you get more comfortable and you start seeing your own results, you start feeling more comfortable delivering more energy into the nodule to really ablate it and to kill it. And so I think, you'll see with anything else, it's going to be experience. I don't think it really will depend on whether you're a endocrinologist, whether you're an interventional radiologist, whether you're a surgeon. I think it's all going to be based on who has the most experience in doing these procedures.
Great. Along the same lines here, can you comment on whether you've had any experience or you're aware of any experience on reoperation after RFA? So that rare instance where you may have a carcinoma that you've decided to use RFA and you've got the emergence of new lymph nodes and you go in, operate, and obviously remove that thyroid lobe at the same time. What is that like?
Yeah, so it's funny you ask. I just did one last week. So I had a patient who was treated at an outside institution for a 1 centimeter microcarcinoma, papillary microcarcinoma, 6 months ago with radiofrequency ablation, and she had a repeat biopsy of that nodule. She had papillary microcarcinoma, so it really did not change from the microcarcinoma was not ablated. So at this point, she just wanted it out and she wanted surgery. She didn't want to have that repeated again. I did the lobectomy, actually just like a standard lobectomy, no issues at all. I think mostly because you're putting the probe into the nodule, and so there's no real, you're not creating any scar tissue around the capsule, you're not creating any scar tissue. It's all intrathyroidal. So the damage that's being done is all intrathyroidal. So from a surgical perspective, the procedure went smoothly. It wasn't like as if the patient had any prior procedure done in the neck. It's basically like having a core biopsy or a large FNA. These needles are 7 millimeters, maybe up to 5 millimeter core tips. And so I think they actually do really, really well. And talking to colleagues around the country and around the world that have done this, nobody's really reported on any complications or any more difficulty doing surgery post radiofrequency ablation. I can tell you that one thing that we have seen now, and I've had one, Dr. Hodak has had one, is capsular ruptures. And what you do is you do these radiofrequency ablation procedures, and we're not really sure what the mechanism is, but it may have to do with really destroying some of the vasculature of the thyroid capsule. And what ends up happening is that it actually you almost get like a herniation of the thyroid. It almost kind of herniates out of the capsule and out into the skin to some extent. And those look horrible. And when you see the patient, it's almost like, oh my God, this is a surgical emergency. You need to take this patient to the operating room right away. But if you just kind of treat them with steroids and antibiotics, it actually settles down pretty significantly over a month, and it kind of almost disappears. So those kind of crazy complications, I think we're going to see more and more things that we haven't seen before because we're doing a new procedure now. But surprisingly, both of those patients were still extremely happy they didn't have surgery. So it's also a lot of selection bias and patient bias here, right? Because they just didn't want surgery so badly. They didn't mind a little thyroid herniating from their neck as long as they didn't have to have surgery, which I'm not sure if that was the right or wrong thing, if you ask me. Surgery would have been fine also. So.
Oh, okay, terrific. Let me ask you a question. We've got a couple more coming in, but I just wanted to ask you about near-infrared autofluorescence. Is this something that you are using on a regular basis now? Do you have selective indications? Can you talk a little bit about cost and time?
Yeah. So when they first came out with this technology, it was called a PTI. It's EYE is the actual name. We actually played around with it myself. At that time, one of my other colleagues that was here, Mike Persky, one of the other attendings at NYU, we played around with this tool a little bit, and we honestly did not find it very useful. And that's just our personal experience. And there may be surgeons out there that find it very useful. In the context of what we do on a daily basis, we felt pretty comfortable in identifying the parathyroid glands. We basically saw the parathyroid gland, and the PTI confirmed that was the parathyroid gland. And so we didn't feel that it was helping us find glands that we would have potentially missed. And also, when we removed the specimen, we would use the technology on the excised specimen, and we really didn't find any inadvertently removed parathyroid gland that we thought would have made a difference, a significant difference in our patients. And I think this goes back to what I said before. I think, if you're a high volume surgeon that's doing this on a regular basis, I'm not sure this technology is going to add that much more to your practice. Once again, if your rate of postoperative hypoparathyroidism is 1% or less, permanent postoperative hypoparathyroidism, this is not going to make that any better, and so I think it really should be used in the context of individuals or places where there may not be that level of high volume expertise. The cost of it, I can't really tell you about how much it costs. I can tell you that it's not cheap. I think the machine itself is close to $40,000 to $50,000 to invest in, and then you have to use some of the probes are disposable, but that costs money as well. And so I don't think it's necessarily going to be cost effective in our practice. But once again, if you have a practice where you have patients who do have postoperative hypoparathyroidism, cost of managing those patients is pretty significant as well. So in that case, it might be beneficial.
Great. What about Indocyanine green? Are you using that? And one brief question regarding this, and I apologize, I should have looked this up, but are you aware of head-to-head? I'm sure there must be evaluations on the use of this approach to assess viability versus an experienced surgeon looking at a parathyroid and judging the integrity of its vascular supply.
Yeah, so the paper that I mentioned actually talks about that a little bit, and there was no significant difference between an experienced surgeon and using ICG. And so ICG, once again, did not add anything over the fact that, that you already had an experienced surgeon doing the procedure. It didn't make a difference. The other paper that I talked about, however, and didn't talk about ICG, but it talked about near infrared autofluorescence, looking at the experience of the surgeon, less than 5 years or greater than 10 years, it did show a difference, where if you had less than 5 years of experience, using the technology gave you the level of experience that an experienced surgeon would have. If that makes sense.
Interesting.
So in that context, it does help. So I think, once again, if you're training residents and fellows, could there be a role for this? Yeah, possibly. I think so.
Great. Are you using it?
We are not using it, no.
Okay. We've got a question coming in regarding the study of lobectomy versus total thyroid for intermediate risk. And the question relates to whether or not there are certain histopathologic features that would drive the decision of lobectomy versus a total thyroidectomy, such as vascular invasion and more significantly, lateral lymph node metastases.
Right. So I think, in general, if you know preoperatively, and I think a lot of this, once again, boils down to what I was talking about, understanding your radiologists and your sonographers. If they tell you that, look, this looks like this tumor has extrathyroidal extension, the feature of this tumor sonographically looks pretty aggressive, you may opt to do a total thyroidectomy up front. Unfortunately, often we don't know these things till after you've done the lobectomy, and the final pathology comes back showing lymphovascular invasion or a more aggressive histology or positive nodes, in which case, you have the discussion with the patient whether or not it's beneficial to go back and do a completion in order to better surveil the patient with thyroglobulin, in order to potentially give radioactive iodine if you think that's going to help. So we don't necessarily have that information up front. In general, if somebody does have lateral nodal metastasis, we do recommend a total thyroidectomy because of the potential need for giving that patient radioactive iodine. Having said that, there was a really excellent paper that came out of Asia looking at doing just a lobectomy and a lateral neck dissection and central neck dissection, and not doing a total thyroidectomy, and looking at survival, and for low volume lateral nodal disease. And once again, it depends on how you define that. If you have an 8 millimeter, level 3 or level 4 lymph node, does that patient need a total thyroidectomy and radioactive iodine? Are you really going to improve that patient's recurrence free survival? And I don't know the answer to that question up front, but I think just looking at the biology of the disease, probably not. And so, do we need to do a total thyroidectomy in all those patients? I don't know. I think that may be a new area of investigation.
Okay, terrific. So let me try to parse out a little bit about your current approach to prophylactic central neck, and just ask you: are there any cases, whether it's a tall cell variant, whether it's a BRAF positive PTC, is there anything that you in a patient in whom you do not identify clinically evident adenopathy, that you will go ahead and do a prophylactic central neck, or do you adhere to basically all comers? If you don't see it, you don't need to take it out.
No, it's more of the former. There are select situations where I will do a prophylactic central neck. And this is in the context of well-differentiated, not medullary, but well-differentiated papillary thyroid carcinomas. I will do a prophylactic central neck dissection. For example, in a patient who has a very locally advanced thyroid cancer, 4-centimeter tumor invading into the strap muscles with locally advanced disease. In those patients, I will do a prophylactic central neck dissection, knowing full well that this patient most likely has a disease there, and I do not ever want to go back into that central neck, because of the extent of disease that was already there. Patients who are more sick, who may be on anticoagulation, who have to stop their blood thinners, you don't want to keep potentially having to bring them back and do more surgery. In those patients, I may consider doing a prophylactic central neck dissection. So there are select situations where that may be beneficial. And like I said, mostly in situations where you have to say to yourself, do I ever want to come back into this central neck? If the answer to that question is no, I'd rather we just take care of it now, then I think that's completely reasonable to do it. I would say by and large, majority of my patients, as long as I have a good imaging study that shows nothing in the central neck, and clinically, I always in the operating room, and you can argue how good is that in the operating room just looking. But when you do a total thyroidectomy or lobectomy, I will take a look at the central neck and kind of put my finger, get a feel for, is there any nodal disease in this area? If I see or feel anything that looks suspicious or worrisome, I will send it off for a frozen section and see what it shows and proceed accordingly. But yeah, in most cases, I will not do a prophylactic central neck dissection, but there are select situations in which I would.
Great, terrific. So I just want to finish up and ask you about your own use of intraoperative neuromonitoring. First of all, is that something you do in all cases? What type of neuromonitoring do you do? And how do you reconcile this quite extraordinary statistic on traction recovery after a presumed traction injury for RLN dysfunction?
Yeah, so the first part of the question, I do use nerve monitoring on all my patients routinely. I didn't for the first couple of years of my practice. I wasn't trained in that way, but over the last, I'd say more than a decade now, I have been doing nerve monitoring on all my patients. Do I think that it's genuinely helpful? I mean, I think there are certain cases where it does help, and there are certain cases where I say to myself, oh, if I didn't have this nerve monitor, that nerve may have potentially been stretched or damaged, or I may have injured it. And it was a kind of aberrant course of the nerve. The problem is I don't know when that's going to happen, and so it's much easier just to use it all the time because you don't know when that situation is going to come up. Obviously, in redo cases, in cases in patients who have had prior neck surgery, I think you definitely have a benefit in those procedures. But I do routinely use it for all my patients. I don't think it adds much in the overall operative procedure. There's no background noise. We do use the Nirvana. It's not continuous. It's only when I want to use it. It's intermittent when I probe something that I think may be where the nerve is. And so that's kind of my practice for nerve monitoring. As far as the second question, I think it's very interesting. I was surprised to see that number. It's much larger than I would have expected. As far as not being able to recover from a traction injury. I mean, my honest take on is the patients who I have had that have had traction injury for the most part have all recovered, and I'll scope them 1 or 3 months out, and I want to see normal vocal cord mobility to truly document and confirm that their cord's working again. Some of it may have to do. Remember, this was a database study, a retrospective database study. So it's hard to assess. Were these patients all scoped postoperatively? Are they just saying based on voice symptoms that it did not recover? That's one thing. The second thing is I think it also depends on kind of where that injury occurs. Most of the time that injury occurs at the level of the insertion. And that happens every now and then when you're right at that last little bit of thyroid tissue trying to remove it, and you notice that, oh my God, I just lost my signal. And that was the traction that occurs right at that, insertion at the cricothyroid membrane. I think those recover pretty quickly. I think if you had a traction injury much lower on the nerve, or maybe at the level of, for somehow I injured the vagus or something, I think that's going to be a much longer recovery time. It may not recover as easily.
So it's also trusting surgeons to give you an absolute honest assessment of what the nature of the injury is. there are any number of things that may lead to loss of signal, whether it's the nature of the dissection or truly attraction. And so I think that's open. That certainly is a subjective assessment of what actually caused the loss of signal. But in any event, listen, this was spectacular. We're up against the 9 o'clock hour. On behalf of our entire audience, I want to thank you for just a wonderful presentation, and want to invite everybody to come back again next week here when we will be there will be a lecture by Dr. Hugh on the management of medullary thyroid cancer. That's on July 7th. So thank you, everyone, and have a great day. Have a great July 4th weekend. Take good care.
Thank you very much. Thank you.
You bet.